Krishna, can I start?
Yes, Usma, we can start now. We are live on Facebook now. Yeah.
So, good evening, everyone. On behalf of Newburgh Diagnostics and NAG Foundation, I welcome you to this session on patient care beyond cancer treatment. This session will be moderated by Dr. Nag. She's a medical oncologist and a director at Director of Oncology Unit, Sayadri Hospital. I also would like to welcome all the panelists today. We have got Dr. Shirish Alurkar, who is a medical oncologist, a director of medical oncology, Apollo CBC Cancer Care, Ahmedabad. We have got Dr. Anupama Mane, who is a breast surgeon consultant at Ruby Hall Clinic. We've got Dr. Udaya Kotecha, clinical geneticist at Newburgh Center for Genomic Medicine. We have Rebecca D'Souza, who is a psychologist at NAG Foundation. We've got Jayashree Kannan, who is a certified whole plant-based nutritionist, as well as a Heal Your Life workshop leader and expert in multiple healing modalities. She herself is actually a stage 3 ovarian cancer survivor and cancer-free for now more than 13 years. And of course, the important person representing the patient community, we've got Ms. Savita Pause, who is a breast cancer warrior. She was detected with breast cancer in 2015. And let's just start the session. Over to you, ma'am.
Okay, so let me share my screen, and good evening to everyone. I think this is a pretty unique concept that Sushma came up with, and that was focusing on patient care beyond treatment. This is something I think oncologists also need to do more and more. And what I thought we'd do in the course of the next hour is just take up a few aspects of patient care and try and answer some questions. Please, to all who are participating in the program or listening to the program, please type in your questions. We will definitely take them up. This is your program, so make it as interactive as possible. So I have a superb panel with me. I have doctors on one side. I have patients on the other side. I have a geneticist. I have a patient come nutritionist, and I have an oncopsychologist. So I think it's going to be a really good session. So without further ado, I want to talk to my doctors. And I don't know if Anupama is here, but I think we'll start with Dr. Alurkar. And Dr. Alurkar, we as oncologists go through a lot in the clinic. And I don't think one ever completely gets used to the fact that one has to break the bad news that someone's lump has turned out to be malignant on the biopsy. So can you tell us a little bit about perhaps what, with your years of experience, how you possibly do it, whether it's to the patient and the family or the patient first? How direct are you when you talk to them? Because we are living in a country where culture and family is so important. So just a bit about how you break bad news to patients.
Basically, it's very difficult to many times break the news, and it's a tricky situation, something like catch-22. Many times the relatives come inside the chamber and don't tell the patient. They keep the patient outside. They hear out everything, the treatment, the prognosis, the cost factor, etc., and then they want us to start the treatment, but then that is not the way to do. I prefer personally to break the news to the patient in a very subtle way. Tell them that okay, it's something like a starting phase of your cancer, but you will need chemotherapy. You'll have to undergo all these side effects. other things. So that is how usually I start. Most of them in our, Indian society, maybe because of our cultural background, as you said, they accept the news quite, smoothly. So we don't really see patients breaking down suddenly, as is what is common, usually perceived. Maybe because they have good social support, good family support at home, as against the Western countries, where it's a very small family, or a single parent. So these sort of situations are not much out here. So they do tend to, accept the news and go along with that quite well.
Okay.
Yeah, over to you.
Thank you for that. I think Dr. Alurkar has very rightly pointed out that very often, and in a lot of socio-economic classes, it's the relatives that come barging into your room and want to know everything before you disclose to the patient. But like him, I myself also like to have a one-on-one with the patient, because in the end, it's the patient and you, and nothing else really matters. It's your honesty, your integrity at stake. So, Jayashree, tell me, you are an ovarian cancer survivor. What was your reaction when you first heard, and who disclosed it to you?
So for me, I was actually unwell for the whole year, and I was going to
Mm,
my general physician, and she
mm,
never really figured out. Uh, and she said, "You're busy, and then you come here when you're sick." And then anyway, so I happened to read an article on ovarian cancer, and I just connected to all the symptoms which that paper said. It
my
came in
goodness.
Times of India, and I said, "Oh God, do I have this now?" So actually,
Mm,
I feared the worst when I went for my checkup. So it was shocking, no doubt. But so when I went for the checkup, I told my doctor I would like to do a sonography now that I have read about it and I feel all of it. So even then she said, no, no, what you read will not be true. So I was really upset because of that I came to know much later. So when I asked um, my onco said,
right,
see, this is the illness where you don't come to know, and actually they don't come to know. And this is one ovarian cancer, something which you really don't come to know, and you don't connect it. You think of all the other things, but not cancer.
right.
So it's not that your doctor was wrong, but this is it. This is the fact of this is this. So I could accept that at that time because my doctor was also very good. I'm not saying that. So it was a shock for her also, that because otherwise I was busy.
So, so you pretty much diagnosed yourself. I think that
Yes,
that's what really happened,
yes,
because
that's
you
what
kind of
happened.
connected the symptoms.
It was
Yeah, that's
shocking, no
quite
doubt.
amazing.
But
Yeah,
I
you had kind of prepared yourself once you saw all those symptoms, I guess.
no, you are not prepared for it, but then okay, the worst, it's worst. Now I need to
Yeah,
come out of it. So when I asked my doctor, okay, how long I'm going to live? Because ovarian cancer is a cancer which spreads and the life, that's what I read. All research said that only. So I said, oh my God. And so he said, don't worry, we will treat it. He was a very wonderful doctor. And but the thing is,
that's great.
when it relapses,
Yeah,
when it really broke down
yeah,
and mattered.
yeah. It's always difficult. Yeah. I think Anupama has joined us. Anupama, are you there?
Yeah, I can hear you.
So,
Tell me.
Anupama, very often you are the person. So, Dr. Anupama is a breast surgeon, and you're the person who kind of gets the biopsy report in your hand after the breast lump has been checked out. And very often you have to sit across the patient and tell them the results of the biopsy. So, how do you do it if it's malignant? And what are the kind of, words or phrases you use, and what has been your experience, and what have been the reactions that patients have had?
So, this is the worst part of my job, I think, disclosing the positive news to the
Yes.
patients, because, I get a lot of
Yes.
patients for very very simple breast complaints, breast pain, and having benign things. So out of them, if a few turn out to be malignant, it becomes really difficult to convey to them. And generally, I make sure that the patient is not alone. There is always a relative or somebody else. Another thing I make sure is not to disclose the report on phone. Nowadays, everybody is in so much of a hurry. They call me up and they ask the reports on phone and WhatsApp. So never do that.
Yeah.
Ask them to come with their closest relative to the clinic and meet you with them. And then when they are
Right.
around, then kind of discuss the report. Tell them that is, I generally tell them it is a positive report. The report of the biopsy is positive. I don't generally like to say it is cancer. Generally not in the first meeting, or not in the first few minutes of telling them the report. So I just say it is positive. It means that it is likely to spread, and then we talk a little technical, that this means this, that, or the stage is this, that. So they do get the answer. But what I've realized is, when you tell them that you have cancer as such, specifically in these broad words, they do tend to break down. They do tend to have a little hysterical reaction, and it's very difficult to manage them. So it requires a lot of counseling. In fact, I would say the first visit with the doctor with a biopsy report probably requires the maximum time, rather than any other visit later on after surgery or chemo or anything. It is the first time that you really
I
have to
absolutely agree.
you really have to talk to them and empathize with them. A doctor has to empathize.
Yeah.
They have to understand what the patient is going through, and try
Yeah.
to give them hope. And it is true, there is hope. However, because of
Yeah.
the big
Sure.
stigma that cancer has become, I mean, people are
Yeah.
very
Yeah.
scared. They are
They are.
unfairly
They are.
scared, I would say.
Yeah, absolutely. In our country, it's like a panic button. And I very often, Rebecca works with me as a psycho-oncologist, and I very often ask her to be around after I've broken the news, because sometimes my busy surgeons are not around and I have to break the biopsy report, and it does get difficult for us. So let's move on to the next question. Uh, so this is one for the surgeon as well. Whose decision is it finally? Because there is so much of misinformation out there. You have a breast cancer, you've diagnosed it, the patient can go ahead with a lumpectomy. It's a small tumor, but you always have to offer both options, lumpectomy and mastectomy. So Anupama, uh, whose decision is it finally? Does the patient always leave it up to you, or do you empower them with enough knowledge to make that decision for themselves?
So it is a combined decision. But the primary decision, I feel, is actually a surgeon's decision to be able to judge whether a lumpectomy is possible, whether the breast can be conserved or not. So that is the primary thing, for which several factors are taken into consideration: whether the tumor is small, the breast is big, whether a good cosmesis will be maintained, all those things. Once that is sure, then we give the choice to the patient that yes, you are fit for lumpectomy, it will be good, or whatever else other factors we discuss. However, always offer them the other choice of mastectomy. Tell them the pros and cons of each. So with the lumpectomy, your breast cosmesis is maintained, and obviously that has a bearing on the overall feeling of well-being that the woman has later, improves her quality of life. But you will also require radiation therapy. There are going to be some radiation related skin and breast changes that you will have to put up with. Then mastectomy, of course, is, cosmetically very disfiguring. You will need to wear a prosthesis. All those things are discussed in details. And majority of the time, the patient takes an informed decision. Majority of the times. There are very few who leave it to the, very few who leave it to the doctor.
Let's go across to Savita. Savita is our breast cancer survivor. Savita, what was your experience? Savita, are you there? Becky, is she there?
Yeah.
Savita Paulos?
Can you hear me?
Yes.
Yeah. Okay. So the day I came to know that I have breast cancer, it's malignant, the first question which came to my mind was, why me?
Hmm.
And within few minutes, I said, no, I never asked this question, why me, when good things happen in life. So that acceptance changed everything.
So, so basically, the question is, how did you decide lumpectomy, mastectomy, or were you not given a choice? I want to
No,
know what was told to you.
I was given a choice of
Right.
both by my surgeon,
Yes.
but since my
Yes.
axillary lymph node was affected, and my mother is a
Ji.
breast cancer survivor, 21 years
Right.
now,
Right.
so I decided to go for mastectomy.
Okay. Fair. Fair
It was
enough.
my
So you took an
decision.
informed decision that
Yes,
Anupama was talking about. That's
yes,
great. That's
yes,
wonderful.
yes.
So moving on, something very practical. And I think Dr. Alurkar can start this. A lot of our patients talk to us about their lifestyle, and they're very curious to know during chemo, after the surgery is done, and even up immediately post-operatively, when can exercise start during treatment? So what do you usually tell your patients?
Yes, I mean, you by that you mean not the physiotherapy, is it?
No, I don't mean rehab. I'm
Okay.
talking about a normal walk. I'm
So yeah,
talking
so
about going back to the gym and doing lower body and not doing weights. You know, there are women who are active, who are conscious about their physical health, and they want to get back into their routine.
So basically, I tell them that see, cancer is a lifestyle disease. So if they're not exercising, they should start exercising. And if
Right?
they're having a sedentary life or a typical housewife, not really exercising, don't have the time to do it, then in conjunction and presence of the husband also, usually I'll tell them that she should go for a walk. At least start with a walk slowly. May not be a gym.
Okay.
Everyone can't afford a gym, or
Of course.
may
Of
not
course.
be possible to go to a gym because of time constraints. So many issues are
Right.
there. So in such cases, once the stitches are out, once the say the drain tubes are out, and everything is fine, and then even during chemo, during radiation, I always encourage them to start exercising. They have to get into that groove of getting exercising and increase the fitness
I think
levels.
it's I think it's very important because I think exercise also helps in reducing the fatigue caused by chemotherapy. There's so much of fatigue that they get, and in fact, one of the things that has been suggested is regular exercise, which could be 20 minutes of walking morning and evening. It could be something very simple, but you have to move. So I think exercise is very important. Becky, do you want to add anything to that? Where is Rebecca? Does any of my panelists want to add a comment to that?
Yeah, I would like to
Work in
say,
our country because of the. Oh, can I just answer?
Jayashree, please
Hello.
go ahead.
Hmm?
Please
So
go ahead, Jayashree.
yes, exercise is very important, I feel, because it really, when you go out and just do a simple walk, it actually helps you to breathe in those fresh air, oxygen, and you get rejuvenated when you come back. So I feel that exercise, when you can start walking after your operation, you need to go out.
Did you do that? Did you
Yes,
exercise a little
yes,
bit?
I did a lot. I used to do 20 minutes of brisk walk and 10 minutes of slow. And of course,
Excellent.
and yoga. But initially, you are so tired that when you do breathing exercise, you might
Right,
sleep. But it's still
right.
nice to keep doing it.
Great, great.
Shona, can I say something?
Of course you can.
I also wanted to say that exercise has it has a psychological impact also. So because there is anxiety and depression and there's fear attached with the diagnosis, I think when you add exercise as a routine, it helps you to release those happy hormones, and
Yeah.
it helps you to control and even decrease the amount of depression and anxiety. So it has a psychological benefit also. So not only for cancer patients but for
Yes,
all
yes.
of us. Yeah, that's it.
So,
So, Dr. Alukar, let's talk about what everybody curses the medical oncologist for, are the chemo side effects. So, the hair loss, which is inevitable with all our breast cancer chemotherapy drugs, for which, of course, we have scalp cooling, but not everybody has access to it. Then nausea and vomiting, which now is very little with the newer drugs, fatigue, diarrhea, mucositis, etc. So when you disclose these side effects to your patients, that's the conversation you first have when they come in and you tell them they need chemotherapy. So the first thing you tell them is you need chemo. The reason you need chemo is, and the side effects are. So do you go into detail with each single side effect? How do you do it in your practice?
So yeah, I tell them the major side effects, which usually if it's a female, they're worried about hair loss. So I tell them in detail that will start occurring about 2 or 3 weeks after the first cycle, depending on what drug we are using.
Right.
And it may come out. I tell a little bit on the hair loss because suddenly one morning or one evening they will find that the whole pillow is full of hair, or the whole floor is,
Yeah.
when they pass their comb around, the whole floor gets full of hair. So suddenly it's quite depressing for the female or
Of
anyone to
course.
see so much hair loss.
Yeah.
I
Yeah.
warn them, I forewarn them this will happen, that you suddenly will find your pillow full of hair. So in such cases, you better go for trimming the hair or shaving it
Correct.
off completely.
Correct.
That is one way of telling. You asked about the other side effects like
Hello?
nausea. So you asked about the
Yeah.
other side effects like nausea, vomiting. As you said, good drugs. To some extent, a lot of psychotherapy also helps. Good support in the family. Exercise also helps because then you are a little fit rather than sitting home and sedentary life, and then going through chemotherapy is difficult compared to a person who is going chemotherapy and exercising. That's what my personal view is. And fatigue, again, exercise, good diet. So I explained to them that what do you mean by exercise. So something at least half an hour of a sweating sort of exercise to the level of sweat. So a little brisk walking, may not be gym, at least some walking. A little younger patient, that maybe some
Of
skipping if
course. Yes.
that way.
Yes. Yes. Savita, you want to share what you went through with chemotherapy? Was
Uh,
it very bad?
yes.
Don't be scared. I'm not
No,
going
no,
to
no,
say
no.
anything.
Nothing like that. After my first cycle, I had a lot of blisters in my mouth. My tongue was like an
Right.
earthworm. And I came running to
Oh my
you
God.
next day. I said, what is wrong with me? All this was not told. And then you calculated the dose, everything, and adjusted it accordingly. And next cycle was little bit smooth.
Okay. And
So,
then it
and then
became more bearable.
yeah, bearable. And then all the side effects, you helped me how to counter them, like that mouthwash with the baking soda and all that, which you told me
Correct.
that did
Yeah.
wonders. And
Yeah.
we have to go through that, nothing else. So
Yes. Yeah.
overall,
Yeah.
it gives you,
Yes.
makes you.
Yes, Dr. Alurkar.
Yeah, one thing, especially when they're female patients, is the blackening of the nails, the
My
nail beds.
goodness. Yes.
And that's really depressing for a patient. They come running, they say, Dekho,
So
kala pad gaya.
what do you tell them? I'm curious to know. What do you tell them when their
I
nails
tell them
start going
apply,
black?
I tell them apply nail paint,
That's
nail polish.
exactly what I do.
Yeah,
I said,
Do
this
it.
is the time to get the brightest nail polish and wear it.
Exactly. Why not going for some skin, massage, face massage, and
Yes,
wrist massage?
yes, absolutely. I tell them
Indulge
to
in
come.
yourself, I tell them.
Yes, yes. Okay. So should I start with Rebecca? I think you'll be honest with me, Becky. Does every
Yes.
patient need a psychologist?
No, I don't think so. I think all of us have some amount of resilience, and we need to measure ourselves first. But we have to, as a doctor, as a medical team, you'll have to give the patient an option that in case you have any problems, there is mental health. There is a mental health professional available. But I think every patient or every person needs that space to decide whether I can manage it on my own or I need additional help. So I don't think everybody needs a psychologist, but they do need somebody who they can just talk to, not in
Right.
that counseling kind of a therapy kind of a session, but in a general session. So not
So
every
tell me,
patient.
yeah, but as clinicians, like Anupama is here, Dr. Alurkar is here, I'm around. How do we tell which are the patients that we need to refer to you? Are there any signs or something we should look for?
it's difficult in the first meeting itself, but I think
Right.
there is instinctively you kind of gauge the patient's perception about how they have accepted the disease. So I think, like, for example,
Right.
if a person is too stoic or doesn't express himself emotion, I think that is also a person that should be referred to a psychologist. Or a person who breaks down and, who keeps breaking down even in the subsequent
Right.
meetings, that's a kind. So I think
Right.
between those two kind of emotional reactions, uh, you
Right.
can, yeah, so you're looking for people who break down too often or who don't express any kind of emotion, because
Yeah.
denial is another way of interfering with treatment, so we need to address that also.
Right.
But
Right. And sometimes,
I think no, I was about to suggest that maybe what we can inculcate is doing like a general symptom checklist. So when a patient comes in, we can just ask them to
hmm,
fill in a questionnaire, which also allows us to understand what is their coping style to trauma, to difficult events. So it gives us a
yeah.
gauge of how they react also.
So it would tell us if there is
So
are
that's
there any
something we can do.
elements of severe anxiety or severe depression. We would be able to pick up with those kind of questionnaires.
Yes, yeah, you can, because like, for example, there is this Edmonton's scale, which gives you
Right.
from severe to mild. So, and
Hmm.
it's a very brief scale which takes less than maybe 5 minutes, but it's a pretty good scale that gives you at a glance. The problem is resources.
Right.
So, like,
Right.
there's only one or two of us in the
Of
field, so it
course.
becomes difficult to
Of
address
course.
everybody. But I think
Of course.
if we can make it available for everybody, it really helps.
Yeah. It'd be great. Dr. Alurka, do you have access to a psychologist in your cancer center?
Yes, we have one. Just recently, a new lady has joined.
Brilliant.
We didn't have last about 1 year, but now she has
Yeah.
joined. Yes.
Great. So I'm sure a lot of your burden will be reduced because, sometimes clinically you're so busy that you just don't have that amount of time to listen enough to patients. I
Consider a
think,
psychologist. Yeah.
yes, I think it's important. So let's look at the rest. Okay. Jayashree, let's go to you first because I believe you are a plant-based nutritionist.
Yes.
So, what is in your mind the best diet to have during and after cancer treatment? And please talk for both the vegetarians and the non vegetarians. So, start with the vegetarians first. I know you're a plant based nutritionist, but can you give us some tips even for the non vegetarian?
Um, so actually how I changed my diet was when I was first time when I got it, the second time when it relapsed, I realized my doctor's just treating me definitely very well, but the healing happens from within me, and I need to look at
Hmm.
my entire cancer in a holistic way: physical, mental, emotional, spiritual. So that's when physical, I felt I needed to add exercise, and I needed to add look at my nutrition. There was very little information, but then I kept reading and understanding a lot of it, because in 2008, 9, 10, there was not much I could think. But the only motivation was when Louise A had written in her book that she went on a whole plant based diet and healed her cancer. This is what I got from that,
Okay.
and I kept reading. So when I read, there's a lot of
Okay.
information. I saw the book Forks Over Knives, and so I felt.
Okay.
So what I picked up was that we need to eat a whole plant-based diet and go off
Okay.
animal products. So that's what I figured out, and that really helped me a lot. All my side effects, because
So
my
basically, you went vegan. You
I
went
went
vegan. That's
I
what
went
you're
a whole plant-based
vegan.
diet, not a vegan.
Okay.
It's like eating whole and complete. Like we are
Yes.
actually. That's what helped me a lot, I would say. So I went off milk and milk products, though I'm a vegetarian, so it was easy for me. But
Hmm.
I really find that really helps a lot, because animal food is highly acidic, and cancer comes, we are
It is.
already in a acidic state. So our body needs to come back
Right.
to pH balance to the. So actually, I read books like written by China Study by Dr. Campbell and Neil Bernard's book, and And there's a lot of books and research material which says that whole plant-based food is good. So, and
Okay.
another thing I read was milk creates those cancer cells. I mean, I don't know. This is all I read, and I just tried it out. And my doctor said, "Okay, if it's working for you, fine, go ahead. You're doing so well." So I
I
know.
think the bottom line is it's got to work for you. I think that's really important.
Yes.
And there is a lot out there on nutrition and cancer treatment. And we recently had a lecture by a medical oncologist from Singapore who's also a cancer nutritionist. And he talked about how sugar was something that needed to be cut out of the diet because
Yes.
when you deprive the cancer cells, the body normal cells can adapt to a sugarless environment, but the cancer cells cannot. And he had some scientific studies he presented as well. So, Savita, did you make any major changes to your diet when you went through cancer treatment and right now when you're a survivor?
Yeah, I always have been a vegetarian throughout.
Right, right,
So I was told to eat eggs, which I tried and I
right.
puked, so I stopped.
Okay,
And then milk quantity I used to take, which I reduced because of the estrogen ERPR positive I was.
correct.
So milk and milk products I have reduced and increased the fruits. Increase the
Okay,
foods. So and eating on time and having
right,
early dinner.
right.
So
Excellent.
these all these changes have been made. More of green
Dr. Alurkar,
vegetables.
what fantastic. Dr. Alurkar, what do you advise your patients? Because they're very, very curious about diet, and that's something that matters, I think, to every Indian. Food is very important to us. So, how do you counsel your patients about diet?
Would be based on the culture, the background.
Right,
So that is most important. For example, I have a patient from Rajasthan. That will be a different outlook compared to, say, a patient from the east. Sometimes even in Gujarat, we have patients coming from the east part who are residents here, but they eat more mainly non-veg. Now, if I tell a patient from Rajasthan to eat eggs, it will be impossible for him to.
yeah, impossible. Yeah,
Yeah, we can't do that. Secondly, about going purely vegetarian and purely vegan, as you said, is difficult in sometime many places, especially like say Ahmedabad, where the temperature of 48 degrees for
yeah,
5 or 6 months away. Where do you get the vegetables? You don't get
true,
anything except some little bit of potatoes and some tomatoes here and there and those frozen carrots. So
correct.
where do you get the fresh vegetable? Even if you do search for the vegetable, they're horribly expensive. So not
Yeah,
everyone can go it. So I make it very flexible. Tell them whatever is available in the
in
shop,
season.
whatever,
Yeah,
in the season, whatever you see on the racks there, you take it, see
yeah,
that it's good, washed, cleaned, everything, and eat it. That's the simple thing.
correct. So, basically, a very sensible approach. Anupama, what is this? Is it a myth, this association between milk and breast cancer? Please clarify that for us.
So milk basically is supposed to be, am I audible? Oh yeah, okay.
Yes,
So milk is supposed to have some estrogens, the hormones actually, which come from these dairy people who inject their cows with the hormones to have a continuous supply of milk while they are milking the cows. So as a result, through the cow, the milk is supposed to be estrogenic. And for breast cancer patients specifically, they are hormone receptor positive. We don't want to give them additional estrogens through the milk or through other similar milk-based products. So that's the reason actually it is told that avoid milk and avoid all milk-based products, avoid soya, avoid all
yeah,
soya products. But, there are a lot of conflicting reports about this. We don't have very, very clear-cut data saying, yes, milk is good, yes, milk is bad. That's very difficult to find. But this is on a very common sense based general assumption that milk would be having some hormones. And as a result, it is not really very good for the patient. But
okay,
the problem arises because we need to, supplement the calcium also. And milk is a good source of calcium. So then
right.
telling the patients not to have milk because of the estrogens, and you're depriving them of a good source of calcium and protein.
And I think even
So,
vegetarians protein, like, so you have to fall back on nuts and I
yes.
suppose pulses and focus on those things rather. But
Absolutely. So it
I
has to
think
be a
just a good sense.
combination of everything. It's very difficult to say avoid this 100%. It's not possible. It's not practical also.
And now there is also some data about how intermittent fasting can help prevent cancer. So there's been a recent publication, but I would caution all our viewers, do what works for you. Please don't compromise on any minerals, vitamins, calcium, and protein. Have a good balanced diet. Don't eat excess of anything, and try and avoid pure sugar in any form. All right. So I think that's the advice that I think we need to follow. Okay. So now we need to come to our geneticist. When do you advise genetic testing for a breast cancer patient, and which test do you advise at that time?
So basically, I mean, when we look at patients for breast cancer, they are referred, most of them are filtered either through the breast cancer surgeon or the medical oncologist. So most of the patients who land up to the genetic clinic are ones who either have had their cancer onset at less than 45 years or have had a family history of cancer. And hence, most of the candidates that we see are ones where we would discuss genetic testing. What kind of genetic testing, again, of course, depends upon the extended family pedigree and what kind of cancers are there within the family. So if it is only related to breast and ovarian, I would concentrate on testing only BRCA, because we have to understand that most of the benefit that we're talking about in treatment terms or risk reduction surgery is all related to BRCA. And if, like, we have a history of colon cancer or diffuse gastric cancer, that is when we start talking about extended panels testing. We do give the options of an extended panel even to breast and ovarian cancer, explaining to them that the more we screen, higher is the chance of detecting a variant of unknown significance, and then you're running from pillar to post because no one knows what to do about it. So that is how we usually go about.
Okay. So tell me then, it's important then to have a facility for genetic counseling in a cancer center.
Yes.
So you would agree with that? It's very important.
Of course. Yes.
And all young women with a strong family history of breast, ovarian, and other cancers should be referred to the genetic clinic.
Yes. And I mean, currently, at least genetic counseling is one thing which could be done, through a telegenetic counseling or through the telephone.
Correct.
Of course, it's one of those counseling which takes a lot of sessions. So I approach like how Dr. Mane does it. In the initial session, we just tell them that, yes, they're probably candidates of genetic testing, explain the tests, give them some material to read about. They can, talk to a few people, discuss in their family, because again, there is cost involved. A lot of patients need to choose when to do the test. So probably if they're on for treatment, they need to first concentrate on completing the treatment and then, talking about their finances for testing, because the test is a bit expensive as compared to normal routine testing.
But Dr. Kotecha, if, for example, like Dr. Anupama and I treat patients together, so sometimes she feels, and I think rightly so, that if she had the BRCA information up front and the lady was found to be BRCA positive, she could offer a prophylactic mastectomy to the patient. Because now women are keen, they're not ignorant anymore. They want to minimize their risk. And although more often than not, they won't opt for a bilateral surgery, there are those women that will demand it. So what do you think about that?
So yes, I mean, if the facility is there and the patient is able to afford the cost, it would always be best that before you start planning surgery, we could give you the BRCA results and then you could taper the treatment according to that. Okay. But in multiple cases, it doesn't happen. It's usually when the patient is on therapy that we are called in for a genetic counseling.
So when they see probably the medical oncologist or they finished with their surgery because they're so keen to get their surgery finished with. Dr. Alurkar, what's your experience with genetic testing for breast cancer?
Test counseling we have to do ourselves. So then we, especially based on the biology, Dr. Kotecha also mentioned various other conditions like diffuse gastric, but one subset would be a triple negative breast cancer.
Yes,
so
absolutely.
PR. So bilateral cancer, maybe subsequently. So those are the cases where we usually advise at least BRCA. And once the testing is done, then I usually tend to send it to the geneticist for
Right,
the exact
right.
pedigree charting and all those things.
Exactly. So there are two aspects. One is for the patient themselves and the therapeutic options, and the other is a family prevention thing that you need to look at also. So yeah, it has a lot of different ramifications. So please, if your oncologist thinks that you need genetic testing, please do visit a genetic counselor. It is important to work out your risks and your pedigree chart. Uh, let's turn to our survivors on the show today. So Savita, any treatment experiences that you would like to share with us? Did you feel that apart from just your surgery, chemo, your radiotherapy, that your other aspects were taken care of?
Yes,
And if
first
not,
of
then
all,
what was lacking?
yeah. The first thing is that the staff at the daycare center and the counselor, they were very supportive. 2 chemos I went alone, and they told me, don't worry, if no one is there, we'll help you out. So that was a best part of this treatment. And
Right,
whenever you go inside, that fear was not there whenever you enter the
right,
daycare. And
right.
you had a good set of doctors who always helped me in any side effect which I had. And when I contacted them for that, immediately that was taken care of. And when the first
Okay.
paclitaxel was given, nothing happened. During the second paclitaxel, suddenly I went dead. And immediately
You
everything
had a
was,
reaction.
yeah, allergic reaction. Everything was stopped, and anti-allergic was given, and then they started over a period of time. So that was it.
So
And
you had an okay experience. It wasn't too traumatic.
no,
Jayashree, what about you?
Mine also was okay. I had my doctor. She would visit my before my chemo, after during the chemo. I had good support system, family support.
Excellent. So I think the bottom line is a great family support system and a good team of doctors is really what you need to get through the treatment and deal with all the side effects in a good manner. Okay. So Savita, to continue our discussion, what are your expectations from treating doctors?
first is that during the treatment, when we start the treatment for the cancer, the line of treatment should be explained to the patient along with the side effects which they can experience so that they are aware of it. Many times it happens that the patient says, भूख नहीं लग रही है मुझे, मैं खाना नहीं खा पा रहा हूँ, hemoglobin कम हो जाता है, and then they realize it very late before the second cycle starts. Then a pleasant bedside manner uh, goes a long way in making the patient calm, is what I feel. And post treatment, the regular follow ups with the doctors, and the doctor should be very stern in telling the patient that they have to come regularly.
Arre
Otherwise,
baapre. Okay.
yeah, yes, yes. Otherwise, patients, they don't go for 2 years and suddenly they realize something is wrong and then they rush. That should not happen,
Right.
because yeah, because that chance of recurrence, why to take chances? What is the harm in
Yeah.
visiting the doctor every 6 months?
I think they just get scared. I think that's
Yes, yes.
something that in our country, people, would rather not know. So that's I think we have to change that mindset. Becky, what do you think that our patients have unrealistic expectations from treating doctors, or are they quite realistic? And how should the doctors handle these expectations?
Can you hear me?
Yes,
Hello? Yeah.
yes,
So I think it works both the ways. Sometimes when the patient is in front of the doctor, there is only partial listening or hearing. They don't hear everything that is being said. So sometimes they pick on a few words and then they have their own perceptions. So they don't hear the word control, that your disease can be controlled. They hear the word that your disease can be cured. So there is this expectation that this disease is not going to come back again. So I think that is a little unrealistic, because if you go with that perception, then follow-ups they think is not required, because anyhow I've taken the treatment, I don't need to follow up. So I think the counseling doesn't really stop at the first session. It continues throughout the entire treatment, because you have to reinforce what you want your patient to understand. So I think in
Yeah.
that sense, yes, many patients have unrealistic expectations, but partly it is because of what they have heard and what they have understood. And they sometimes you don't want to hear the bad news, so you just
No, you
focus on
don't.
what's
You
the
just
good
want to hear the good
in
stuff.
that sense.
Okay. So, Dr. Alurkar, PET scans have become
Yeah.
a big fashion statement, and sometimes I have patients coming to me even before a biopsy diagnosis with a PET scan in their hand. So, are they really required for breast cancer patients, and when would you really advise it?
See, the guidelines, the medical guidelines, which are there like NCCN or ESMO or whatever, they don't really recommend PET scans in an
Exactly.
early stage breast cancer, especially when you're contemplating surgery upfront. You don't really need the PET scan. But definitely, if the patient has a recurrence of disease and there is some symptom which is unusual, like say back pain or
Yes.
headache, or I would not say headache, but a little bit of any other symptom. So in such cases, definitely a PET scan, whenever there's a recurrence of disease, yes, 100% PET scan would be needed to decide the further course of treatment.
Anupama, are you okay with that? That you would not do it in
Yes,
a early breast cancer setting, but if you have a very large tumor and you're ruling out spread anywhere, that's the time you would consider it, or to look for a
absolutely.
recurrence?
Yes. So
Yeah.
stage
So
3 and 4 clinically, I would say
yes,
yes.
you would definitely want to do it. Okay. Becky, how do we reconcile patient versus family wishes? Sometimes we do have a lot of discordance between what the patient wants and the family wants. Sometimes, unfortunately, when things get out of hand and the patient has reached a stage 4 disease, the patients are really not too keen on further treatment, but the family sometimes might want to push. So, how do we reconcile both these situations?
um, it's a very difficult cash 22 kind of situation, because the family doesn't want the patient to know the extent of the disease or even the diagnosis of the disease. So I think talking to the entire unit as a whole will really help. It's not like, so when a family says that please don't discuss it in front of the patient, I think it is important for the doctor to emphasize that it is the patient's right to know what she or he is undergoing. So you become a, and we've always said, no, oncology is a multidisciplinary team of doctors,
Absolutely.
and the patient is a part of that team.
Right.
So I think sometimes we tend to give in to the family because it's easier to deal with them, uh,
Yeah.
because they're so insistent, or they're so aggressive. But I think as a treating doctor, to insist that you may not need to tell her the true extent of the disease, but you need to, at least she should understand what's happening to her. And that creates a lot of problems when the patient doesn't know what is happening, because they come up
The
with their
true
own
picture.
answers. Yeah. So
Yeah.
they don't know what they're dealing with, and it's like they're going blind. So I think
Yeah.
it's
Yeah.
difficult, but I think we have to give the patients that we should ask them
Yeah.
that I think it's better to get them to involve
So,
the
anybody
patient.
had any experience with this kind of situation? Anupama, have you, Dr. Alurkar, where there has been a discordance between what the patient really wants and what the family wants?
Not really.
Hmm.
They might have minor issues, but the
Hmm.
patient usually comes around to the family's wishes. I've
Hmm.
realized that because the family is aggressive and insistent, and the son and the daughter, they
Hmm.
kind of forcibly tell the mother that this is what she has to undergo and this and that. She listens to them.
Hmm.
Females being biologically, you can say, maybe docile by nature. If the husband tells her something, she agrees to him. The family,
Okay.
son, daughter say she agrees to them. So ultimately, I've realized the patient's wishes are similar to the family wishes.
Okay. All right. So, Dr. Alurkar, what is your take on alternative therapies? Because whether we like it or not, whether we approve or not, I think studies have shown that almost 90% of Indian patients are on some kind of alternative therapy. And this can happen easily without our knowledge. So, what is your take on this?
I would say about 50% would be taking something which they don't disclose in some homeopathic, Ayurvedic, or many things. So we really have to ask them repeatedly at every visit. Practically, we have to ask them, do you take this? Do you use that? Do you use it? And somehow sometimes they come out with it. The rest don't usually. They are quite, as doctor someone said, they are quite subservient, the patients, to the doctors. So they do follow. If you tell them you stop Ayurvedic, homeopathic, at least till the chemotherapy is on, they do obey, they do follow.
That's what I tell them as well. Yeah.
Once you're out of all this chemotherapy, and then you can go back to the alternative medicines.
Jashi, did you pursue any alternative therapies during your treatment or after your treatment?
I did not take any of these treatments like Ayurvedic and all, but I did a lot of mind body work. I worked on emotions, and I just
Fantastic.
practiced whole plant-based food. So I
Okay.
just changed my diet, and I
So these are
went
the two
ahead.
things that you did.
Yes, and I follow it even now. So that's what really helped me, because there was a lot of issues which I needed to look into deeper within myself. Cancer was my external symptom and manifested illness, but there was something deeper down which I needed to look into so that I don't get back the illness. So it's a lot of mind.
So it was like a wake-up call for you to reflect within. That's what you're saying? Okay, fantastic.
I did, of course, I got certified. I learned a lot about this whole plant-based nutrition. I certified myself. And
Really? Okay.
that helped.
Savita, did you pursue anything, or are you pursuing anything right now?
Yes, during the chemo, I took homeopathic to counter the side effects.
Okay.
Because I could not take allopathic due to my mild hiatus hernia, which I have. So
Yeah.
most of the medicines, they just don't suit me. So I went for
Suit you.
homeopathy. Yeah.
Okay.
So I went for homeopathy, and it helped me a lot to counter the side effects. And now also for general like body aches, bone joint pain, I take homeopathic.
You take homeopathy.
Yes.
Okay, fine. So before we come to the end, are there any questions that we should be taking from the chat box? Sushma? Is there? So I'll stop sharing right now. Is there anything that is, oh my God, there's so many. Okay. So there's one question that has come in is, where are these genetic clinics? Is there any clinic at Odisha? So Sushma and Dr. Kotecha, can you guide this patient accordingly? So this is Indira Naik. And if you can do a maybe online session and guide her correctly, that would be fantastic. Okay, another question. How is BRCA testing used in treatment options? And does BRCA testing alter the treatment options? So Dr. Kotecha, you want to start? How is it used in treatment options?
So usually if you are BRCA positive, then there would be a risk of contralateral breast cancer, and there would also be a lifetime risk of ovarian cancer, which would again depend whether you have BRCA1 or BRCA2 mutation. So as I think ma'am had earlier said, so when you are undergoing a surgery, the surgeon would offer you a bilateral mastectomy, because if you go for a bilateral mastectomy, you reduce the risk of breast cancer by up to 90%. Similarly, if you go for what we call a salpingo-oophorectomy, that is removing both ovaries as well as the fallopian tube, then you reduce your ovarian cancer risk by up to 80%, and you reduce your breast cancer risk by up to 50%. So depending on what mutation you have, whether you have BRCA1 or BRCA2, we also give you, there is the benefit for the oophorectomy would differ according to age, whether you have BRCA1 or BRCA2 mutations. If you have BRCA1, we tell that you need to go, if you really want to get the maximum benefit out of the salpingo oophorectomy, because that would affect your reproductive options, that would affect your reproduction. So that needs to be done around 35 to 40 years. And if you have a BRCA2, you can plan that around 40 to 45 years. It's also important that if you have a BRCA mutation, there is a 50% chance that your first degree relatives, your offsprings could also inherit the mutation. And through your mutation, we could actually test if they are willing other members in your family who are at risk, and anyone who is at risk could be either put on to screening on a regular basis or could be offered the risk reduction surgeries.
Excellent. So I think Dr. Kotecha has given a very comprehensive answer. Anupama, you want to take this one? So Janet asks says that relapse no doubt depends on biology of disease, not the type of surgery. But in your experience, does mastectomy help in preventing relapse to some extent?
So mastectomy definitely helps in preventing relapse, as would a breast conservation surgery. I mean, obviously you're taking out the tumor from the body, that helps in prevention of relapse. But if the margins are free, as in breast conservation surgery, then the risk of recurrence is the same in mastectomy vis-a-vis breast conservation surgery. So yes, mastectomy helps in preventing relapse. Yes, breast conservation surgery also helps in preventing relapse. Which surgery is right for you, the doctor and you will decide for yourself. So both help in preventing relapse to an equal extent.
Okay. So I think okay. Another one that has come in, Dr. Rebecca has asked this for the benefit of everyone. Dr. Alurkar, what options are available for young women in terms of fertility conservation?
Even before starting the chemotherapy, you usually refer to the gynecologist or the fertility specialist. And usually I don't decide what sort of fertility processes and methods to be done. It's the gynecologist or the infertility specialist who does it. So whether it's an oocyte preservation or
right,
or embryo preservation, that's up to them. So they decide.
Right.
Basically, based on the urgency to start the treatment.
Correct.
So,
and I think we are always in a hurry. In a couple of weeks, 2 to 3 weeks, we like to start the chemotherapy, especially in younger patients. And there is also a possibility of an injection that you can give, and it's called Zoladex. And you can give it every month. You start before the chemo, and you give the last dose after the chemo. This can protect the ovaries to some extent. But again, talk to the gynecologist as to what's the best option for you. All right. So I think that's important. So I think we've had quite a comprehensive session today.
And just one important question.
Yes, Sushma.
Due to COVID situation, there's one question which says, due to COVID situation, I've not been able to do my regular follow-up. Is it okay? Or should I visit the hospital even now for a regular follow-up?
No, it's not okay. And I cannot emphasize more that we have had so many ladies who waited for the COVID situation to get over, and they've delayed their diagnosis and come back with huge lumps. There are those that have not come for fear of COVID, and after 6 months, I have found disease where I shouldn't have found it, or I would have picked it up earlier. So please don't delay your follow-ups because of COVID. The problem is getting lesser and lesser now. COVID has a mortality of 1.5%. Breast cancer has a mortality of 50% if diagnosed in late stages. So please put it in perspective. You find a breast lump, please come. If you're due for a regular follow-up, don't delay it. All right. So this is my sincere message to all of you out there. Sushma, would you like to make some concluding remarks and wrap up?
Yes. Thank you, Nag Foundation, Dr. Nag, and all the panelists. I guess this was a wonderful session, and so many important points that were brought up. So thank you, everyone, for joining in.
Thank you. Thank
Thank
you.
Thank
Thank you,
you.
Anupama. Thank you, Dr.
Thank you.
Alok,
Thanks.
Jayashree,
Bye.
Savita,
Thanks.
Dr.